Welcome, scholars. Today we're discussing the first half of chapter 18 in your book, which is all about the heart. And if you know me at all by now, you know I like to start our time together with a little joke. So here's your joke for the day. All right, so the heart is a pump, surprising no one, right? Actually, it's two pumps that exist side by side. The pulmonary circuit is the right side of your heart, and that's where we're going to have oxygen-poor blood coming in for the body that gets sent to the lungs for the gas exchange. And then the left side of the heart is your systemic circuit that gets the high oxygen-rich blood from the lungs and is going to send that blood all the way out through the body. Okay, the heart is an organ of chambers and valves. So when we talk about the circuit of the heart, this I feel like can be a little misleading because when I think of the circuit, I immediately think electrical, right? So now the heart has electrical systems too, right? We're going to talk about that today. But for now, let's focus on the mechanics of how blood moves through the chambers and valves of the heart. All right, so in the simple pulmonary circuit, we've got low oxygenated blood that you often see in diagrams as blue that's going to come in to the right atrium. It's going to come in through the superior vena cava, it's going to come in through the inferior vena cava, and it's not shown on this diagram, but there's another opening that allows blood to come in from the coronary sinus. So the coronary sinus is venous blood coming back into regular circulation from the heart muscle itself. So we'll talk about that in a little bit. All right. So venous blood, low oxygenated blood is going to dump into the right atrium and it's going to pass through the atrioventricular valve. And on the right side of the heart, that's the tricuspid because it's got three flaps, the tricuspid valve. It's going to dump into the right atrium. And then during contraction of the ventricles, it's going to get shoved, it's going to get ejected out through into the pulmonary system, through that pulmonary semilunar valve, into that pulmonary trunk artery to get sent to the lungs to do gas exchange. All right? So arteries, this pulmonary arteries are any vessel that takes blood away from the heart. So even though this is low oxygenated blood, and oftentimes we think about arterial blood always being red, high oxygenated blood, but here in the heart it is not. So the pulmonary arteries have low oxygen blood to go to the lungs to get that gas exchange. All right, so coming back, we've got high, now we've completed our gas exchange in the lungs, and now we've got high oxygen-containing blood, which in diagrams you're often going to see as red. It's going to empty into that left atrium through pulmonary veins. So just like the pulmonary arteries took blood away from the heart to the lungs, pulmonary veins are now going to bring blood back to the heart. So veins always bring blood back to the heart, even whether they contain a lot of oxygen or not, whether that blood, contains lots of oxygen or not. All right, so pulmonary veins are going to empty into that left atrium, and then blood is going to pass through that left atrioventricular valve. This valve is called the bicuspid valve because it only has two flaps. On the right, we have the tricuspid with three, and on the left, we've got the bicuspid with two. Take a second and think about that. Why do you think there are only two flaps on the left side of the heart in between the atria and the ventricle? There's a reason for it. Maybe think about that for a little bit. All right. So, as blood gets emptied from the atria into the ventricle through that bicuspid atrioventricular valve, then during contraction of the ventricles, a high oxygenated blood is going to be ejected through this aortic semilunar valve into the ascending and then the aortic arch, and then out through the aorta into the many, many branches that will take high oxygenated blood throughout the body. All right, so did you have a chance to think about why this atrioventricular valve only has 2 flaps? Think about the pressure differences that you would see in the pulmonary system versus the rest of the systemic circuit, the pulmonary circuit versus the systemic circuit. Big pressure difference, so we want 2 valves are easier to stay closed than 3 against high pressure. Okay, here are a few fun facts about your heart. The average human heart weighs about 300 grams, which if you make a closed fist, your heart is about the size of your closed fist. It's enclosed in the mediastinum, so think back to, chapter 1, when we talked about body cavities. So the heart is enclosed there in the mediastinum, and it's anterior to your spinal column, and it is deep to your sternum. It is like an inverted triangle. It's got a wide base and a small pointed apex. The wide base is superior, and that's where all those great vessels exit from the organ. And that pointed apex is going to point kind of down towards your left hip, and the right, basically most of the right ventricle sits right here on top of the diaphragm. Now, the pericardium is a double-walled, super durable fibrous sac that surrounds your heart and great vessels. And most of us, we really don't give a lot of thought to this super important structure in your body, right? It gives a lot of support to this continuously moving organ, and it keeps your heart in its proper place inside your thorax. And if you those of us who like to exercise, we appreciate that, right? Imagine if when you're running or exercising hard and your heart really gets going, imagine if your heart was thumping around all over your chest. That would be a big fat problem. So we're thankful. Let's give the pericardium a little love. Now, another thing, flashback to AP1, remember when we talked about body cavities and the visceral and parietal serous membranes that line our organs and the walls of body cavities, right? I think that was way, way back in chapter 1. So in the pericardium, this really gets important. I mean, it's important everywhere, but it really gets important in the pericardium, right? Because that super tough sac to hold your heart in place, it needs proper amounts of fluid surrounding it for lubrication. That heart's constantly moving, and the visceral and parietal serous membranes are going to secrete just a little bit of fluid into that potential space, and that fluid minimizes friction as the heart is doing its work day after day, year after year, right? So minimizing friction is super important to prevent damage to heart tissues during that constant movement. So, what if your heart was not anchored down? If your heart was not anchored down as well as it is in your pericardium, then like this little eyeball, it would be jumping all over your chest during any form of exercise, and that would be very damaging and very uncomfortable and wouldn't be compatible with your life. Let's not say that again. Okay, now let's talk about inflammation of the pericardium. So now you know what normal is supposed to look like, and of course disease processes happen, and there's many, many different reasons why you could have inflammation. So when you see a word, so peri means around, card means heart, and itis means inflammation. So anytime you see a word that ends in itis, think inflammatory process. All right, so this is an inflammation of that pericardium. And one of the first symptoms that can happen in our patients is they'll say, yeah, I feel like it's weird, deep pain right underneath my sternum, kind of feels like heartburn. So that can be one hint that we've got pericarditis coming if we know our patient's at risk. Now, once it's there, once we truly have inflammation, then you may be able to hear what we call a friction rub. And that is a kind of a creaky or a grating or a scratching sound when you listen to the heart. I don't have an example of that for you. Well, we might be able to find one on the internet, but the ones I found were not great. But if you happen to be in practice on your clinicals, you may encounter a patient who's got pericarditis with a friction rub, and that's super interesting. All right. Now, if pericarditis progresses, sometimes we can get what we call pericardial effusion. So again, we have this heart, this beautiful, mobile, constantly moving organ is enclosed in a fibrous sac. And we've got a little bit of fluid where normally, like on the picture to the left, we've got a tiny bit of fluid inside that sac that helps to lubricate and minimize friction as the heart is doing its work. But in the presence of infection or other inflammatory processes, then those serous membranes secrete too much fluid, and we can get a buildup of fluid inside the heart, which is a big fat problem. Now remember that pericardial sac, super durable, doesn't stretch. And think about for one moment, what do you think would happen if we've got a buildup of fluid inside that sac? Yeah, all right. So Physics 101 says you can't compress fluid, and human bodies certainly cannot. So if you've got a buildup of fluid in that sac, it's going to put external pressure on this delicate organ, right? So imagine what's going to happen is that the heart needs to be able, that muscle needs to be able to stretch and dilate in order for those chambers to fill properly with blood. And if we've got external pressure coming on that organ, then its filling will be impaired. So when that happens, we've got too much external pressure compressing the heart that does not allow it to fill properly. We call that tamponade, all right? And that requires us to do something, right? So what we're going to do is we're going to stick a needle into the chest through an intercostal space, and we're going to stick a needle into that space, and we're going to draw that fluid out. All right, when I think about the myocardium, like the actual structure of the muscle fibers, it's gorgeous. It really is intricate and beautiful. So the cardiac muscle itself are arranged in these beautiful circular and spiral bundles, and they're anchored together with some connective tissue fibers that kind of crisscross and provide support, and we call those fibers the cardiac skeleton. So this organ needs lots of reinforcement. Again, it's moving throughout your lifetime, and with exercise it has to work harder. So we want to make sure it is structured, it has good structural integrity, and those crisscrossing cardiac skeleton fibers provide that integrity. All right, lots of support, especially to the valves themselves and to those great vessels. So when I think about the squeezing action of the heart, when I first learned about this, I got, okay, yeah, the atria contract on the top, and then the ventricles contract, so it's kind of the top to bottom, squeezing the top, squeezing the bottom, top to bottom, top to bottom. So that's simplistic, right? And if you think about that, that's kind of like if your hands were simply squeezing the water out of a sponge, right? You can squeeze quite a bit of water out of a sponge. But really, in reality, the whole organ is going to squeeze and then twist a little bit. So the true action of the heart is closer to what happens when you wring water out of a sponge with both hands. Or I'm sure all of you have had a wet towel or really wet piece of clothing, and to get the most water out of it, you're going to twist it and squeeze, right? You're going to twist and wring. So that's really what's happening with the heart. And I remember when that light bulb went on for me, and when I was in cadaver dissection, and we had taken the heart out of our cadaver, and we were really dissecting down the muscle fibers in the heart, and I thought, oh, wow, okay, that makes more sense when I see the directional fibers, this improves efficiency of this organ. Fascinating. All right, let's talk about the different chambers of the heart, right? So we're still in the structure of the heart. So the atria are the two superior thin-walled receiving chambers. This is where blood comes, venous blood from the body or venous blood from the lungs, empties into these two chambers at the very, the superior base of the heart, all right? From the outside, they kind of look wrinkled, and the wrinkling on the outside is called an auricle. Kind of looks like ears. So to someone thought it looked like ears. I guess if you use your imagination, it kind of looks like elephant ears. But those auricles allow for dilation, allow for expansion of those chambers as the venous blood flows in. It doesn't show it well in this diagram, but the atria itself, and we'll see that more when we do our heart dissection, is divided by a septum, an interatrial septum in between the atria. And in adult humans, we're going to have a shallow depression kind of in the center, the medial center of the atria, and that depression is called the fossa ovalis, and it's a remnant. It's a remnant of the opening, that foramen ovale, when we were fetus in our mother's uterus, and we had blood being able to bypass the lungs for the most part. We'll talk about that more when we get to. We'll talk about that more a little bit later. But for now, just kind of remember that fossa ovalis is the remnant of the foramen ovale. All right, here's a posterior view of the heart and a good highlight of the coronary sinus. So we had mentioned before when we were looking at the right atria that there are 3 vessels that empty venous blood into that chamber. So the first one is the superior vena cava. The second is the inferior vena cava, and then this coronary sinus is the third. All right. So this is venous blood from the heart muscle itself that needs to return to general population, right? To general circulation, and that coronary vein, all the coronary veins are going to bring blood back to this big coronary sinus, and then the sinus will dump into that right atrium. Excuse me. All right, the ventricles are our discharging chambers. And the ventricles these are our action chambers, right? These are the real pumpers. If you look at the diagrams, our atria are super thin walls. They're muscle, but they're not nearly as meaty and beefy as the ventricle chambers are. So the ventricles have much thicker walls. They're much stronger muscles. Inside, they've got kind of irregular ridges, and those are called the trabeculae carnae. Think for a second. Why do the openings of the atria are very smooth, but the ventricle walls, the inner ventricle walls, are not. They are kind of lumpy, bumpy. Why do you think that is? Yeah, take a minute to think about that. What would be the benefit of that? Our human bodies are really efficient. We're not going to have things that aren't necessary. Okay, so thinking about that, I hope you thought that as the blood from the atria empties into the ventricle, we want to keep blood moving. We constantly want to keep blood moving. So if we have irregular, irregular walls in the ventricles, that is going to keep our blood moving and churning around. Blood that stagnates clots. So we definitely want to keep blood moving, and these irregular surface area helps to do that. All right, so inside both ventricles, we also have these little papillary muscles. The papillary muscles are connected to the atrioventricular valves with these little threads that are called the chordae tendineae. Now they look thread-like, but they're pretty strong. You'll see that again when we do our heart dissections. And as these papillary muscles contract, they pull on the chordae tendineae, and that pulling action actually closes the atrioventricular valve. Very cool. So we want to keep blood flowing one way only. It's a one-way path, right? We do not want to take we don't want our blood going the wrong way on the exit ramp, right? Just like you don't want to go the wrong way on the exit ramp on I-95 to get, if you're getting on I-95, you do not want to hit the exit ramp. You want to get the on-ramp. So we want to keep blood flowing in one direction, again, to keep it moving through efficiently as possible and to prevent clotting. So when you think about the pulmonary circuit, the right side of the heart, and the systemic circuit, the left side of the heart, we are going to be moving equal volumes of blood, right? Equal amounts of blood. But the workload of the heart from right to left is uneven, not the same. So the pulmonary circuit, super short, right? The lungs are in the neighborhood. They are right next door. We don't need a massive contraction to send blood shooting into the lungs. They're really close by, and lung tissue is delicate. This is a low pressure system. Now, on the flip side, the systemic circuit, much longer. As far as we're going to send blood through the aorta and out to the entire rest of the body. So it's got a much farther way to go, and it's much higher pressure, and all of those vessels that need to be served offer about 5 times the amount of resistance than the pulmonary vessels do. So the workload, very, very different, right to left. All right, so the muscle is a heart. The heart is a muscle, right? It's a bundle of muscle fibers, super important muscle fibers. So those muscle fibers need blood supply too, of their own, right? And how does your heart muscle get its oxygen and nutrients? From the coronary arteries, okay? So the myocardium, the heart muscle itself, super thick, right? Especially down in the ventricles. And so it's too thick to get its nutrients through simple diffusion alone. So our coronary arteries kind of arise, they come off of the very base of the aorta, the very, very beginning of the aorta. And they come around the heart to the right, to the left, and encircle the entire organ. And during diastole, when the heart muscle is completely relaxed, and the aortic semilunar valve is closed, a little bit of oxygenated blood is going to backflow, and that backflow pressure is what allows these coronary arteries to fill. So the right coronary artery supplies the right side of the heart. The right coronary artery and its branches, supplies the right side of the heart. And the left coronary artery and its branches supply the left side of the heart. Now, if you look at the diagram here, we've got many, many more arteries supplying the left side of the heart. Why do you think that is? Think back to a couple slides. The work of the left ventricle is much more significant than the work of the right ventricle. So it needs more oxygen. That tissue is going to need more oxygen. All right, coronary artery disease, #1 killer in our country. No fun for anyone. And this is when those coronary arteries, the arteries that feed the heart muscle itself, become blocked. And there are lots of different risk factors that contribute to this. Smoking, huge. Lack of exercise, obesity. There are genetic factors involved. All of those things, but very dangerous. And we want. I hope someday we can conquer this problem. All right, myocardial infarction, also known as a heart attack. Okay, so again, when we have blockage of one of those vessels that feed the heart muscle itself, then the heart muscle gets deprived of oxygen and nutrients. And guess what? Heart muscle, very, very sensitive to a low oxygen environment, like we talked about before. And Heart muscle cells are amitotic. What does that mean? What does that word amitotic mean? Think about that for a moment. Okay, so amitotic means they don't divide. They don't go through mitosis. After the heart has reached its adult size, its fully formed size, then we do not replace heart cells. So heart cells that are killed or are significantly damaged because of a low oxygenated state, because of a blockage in one of those coronary arteries, do not get replaced with new heart tissue. They get replaced with scar tissue, which is unfortunate. Scar tissue does not respond to the electrical impulses, and scar tissue will not contract in the way that the rest of the healthy heart muscle will. All right, let's take a quick little flashback to AP1 when we're talking about cardiac muscle tissue and what's special about cardiac muscle tissue. Cardiac cells, as you might remember, short, fat, organized, kinda, not in the same beautiful way that skeletal muscles are organized, and they're interconnected by these dark bands of, we call these intercalated discs, all right? In those intercalated discs, which is super important to heart function, you're gonna see gap junctions. Those gap junctions connect the cells together electrically and help that tissue function as a team or a unit. So when we want the heart tissue to contract all at once and then relax all at once. Now you're also going to see desmosomes, which is like a cellular Velcro, and that's going to help prevent cell-to-cell separation. Again, your heart is moving all the time throughout your lifetime. So we want that tissue to be durable and sustainable. And desmosomes help that happen. All right, we're still flashing back into AP1. You'll remember cardiac cells have a whole bunch of great big mitochondria, right? It's those mitochondria, the powerhouses of these cells. They're going to occupy about 30% of the volume of every cardiac cell, right? Cardiac cells, super active throughout our lifetime. They need lots of oxygen, and those mitochondria supply that oxygen. Having so many mitochondria and so many large mitochondria enable your cardiac cells to be resistant, super resistant to fatigue, tiring out. Okay, if we were together in a classroom, this is a place where I would give you a break. So take one now. Pause this video, get up, walk around, get a snack, do some jumping jacks if you need to get your blood moving, whatever you need to do. I remember how intense it can be learning this stuff. So give yourself a little love and take a little break right now, and join me again in a few minutes when you're fresh. All right, welcome back. I hope you had a nice little refreshing break, and I hope you're ready to finish up this section. All right, so let's talk about how cardiac muscle physiology is different from skeletal muscle, all right? So when you think about the pacemakers, about 1% of your cardiac muscle are pacemaker cells, and those cells are self-excitable. What does that mean? Right? It means that they don't need nerve stimulation to do their job. Like, they don't need signals from your brain to say, time to contract. They are automatic, do it all by themselves, right? Your heart tissue is also going to work like a team. And we talked about that just a few minutes ago. As the electrical stimulation moves through heart tissue, cardiac tissue, that depolarization, as it moves cell to cell through those beautiful gap junctions, we want all of our fibers to contract, or none of our fibers to contract, right? We want a full contraction and then relaxation. That allows our heart to act as a pump. Cardiac cells are going to use up a lot of calcium, right? We need calcium for muscle contraction, whether it's skeletal muscle contraction or cardiac muscle contraction. And because we're doing lots of contraction, continuous cycle of contraction and relaxation, we're going to pull calcium, not just from the sarcoplasmic reticulum, like we do in skeletal muscles, but we're also going to pull some calcium from that extracellular fluid. All right, flashback to AP1, Chapter 9. So in skeletal muscles, we get tetanic contractions. So remember back in Chapter 9, we talked about how skeletal muscles use summation and recruitment for graded muscle contraction. That allows us those fine motor skills. And if you've forgotten about that, then you know what you need to do. Go back, refresh your memory. Heart muscle behaves very differently. We do not want graded contractions in our heart muscle, right? If that happened, then we wouldn't have full relaxation, which would allow the atria and the ventricles to fill, and our heart would be useless as a pump. So we don't want that to happen. Now, I alluded to this a few minutes ago. Our heart relies exclusively on aerobic respiration, meaning the heart has to have oxygen. Now, because cardiac muscle has so many great big mitochondria, this tissue completely oxygen dependent for its metabolism, right? So this is one of the reasons why cardiac tissue is one of the two types of tissue that really plays into the rule of fours, right? 4 minutes without oxygen and cardiac tissue begins to die, right? Skeletal muscle is different. It can use direct phosphorylation or anaerobic pathways, and then it can replenish itself with EPOC, but cardiac tissue, not the same. All right, so now let's talk about how electrical activity flows through the heart. Now, you understand how blood moves through this awesome, amazing organ. And so now let's move on to how electrical impulses move through. As we're going to go over this pathway, I want you to keep this in the back of your mind, right? Electrical changes in this organ will cause pressure changes, right? Pressure changes in the chambers, and pressure changes eventually will in the vessels going away from the heart. Those pressure changes inside the chambers are going to cause mechanical changes to the valves. All right, so just kind of keep that in the back of your mind as we go through this. All right, so we're talking about the way cardiac tissue conducts electricity. It's going to start at the SA node. And I've got a little arrow, and your book goes through this beautifully. So if I'm going through it too fast, go back, look at your book. You can pause the video and take it step by step. Do what works for you. All right, SA node's going to set the pace for the heart as an organ, all right? And that SA node is going to generate impulses at about 70, 75 beats a minute, kind of depends, right? Okay. Then, as depolarization is going to spread throughout both of the atria, there are internodal pathways. So gap junctions are taking this electrical impulses all the way across the base of the heart through that internodal pathway. Then the electrical impulses will hit the AV node, right? The atrioventricular node. And we're going to have just a slight little delay. And if you think about when you listen to the heartbeat, there is a slight delay between the thumps. So we have a little delay there. All right. And that delay allows the atria to kind of finish their contraction, to finish their emptying of blood into the ventricles before the contraction of the ventricles begins. All right. Then from the AV node, our electrical impulse is going to pass into the ventricles through a shared pathway, the AV bundle. Then that atrioventricular bundle is going to separate into right and left bundle branches to send stimulation out through the ventricle. That conduction will go through the interventricular septum and then out to the ventricular walls. And then, last but not least, the Impulses get conducted out into the muscle tissue itself through that subendocardial conducting network, and when that happens, the ventricles contract. The flow of electricity through the heart happens so fast. It only takes about 220 milliseconds from start to finish in a healthy human heart. All right, so just for comparison, that's about half the time it takes for you to blink your eyes. Whew, fast. All right, so when we've got defects or faults in that conduction system, we get arrhythmias, all right? So the normal rhythmic function of the heart is very orderly and controlled and coordinated, right? The atria fill and then contract, pushing blood into the ventricles, which then they fill, and once they've reached maximum fill, they contract and eject blood. Wonderful. When we have damage to our electrical conducting system, then we have errors in how the heart functions. So we can get what we call ectopic pacemakers. So an arrhythmia, I'm going to back up a second. An arrhythmia is when the heart's function gets uncoordinated, right? When we don't have a nice rhythm in between how the atria behaves and how the ventricles behave. So when we have that happening from an ectopic pacemaker, then we get a premature contraction or an extrasystole, right? And that can feel kind of like a thump in the chest. And usually that's because we've had too much coffee or Red Bull or whatever your caffeine of choice is, or another stimulant. We've got lots of different chemical stimulants. And it can feel really weird, super uncomfortable. Most of the time it's harmless, thank goodness, right? Annoying but not dangerous. Okay. When we have damage to that atrioventricular node, then, or to the bundle, the AV bundle, or to one of the bundle branches, one or both of the bundle branches, then we get what we call heart block. Now, heart block can be first degree, second degree, or complete, and you don't need to worry about those differentiations right now. If you go into cardiology, you'll learn more. Now, if we have damage to one of these structures, then the intrinsic rate of ventricular contraction, the autorhythmic cells of the ventricles are super slow. The autorhythmic cells rate is only about 20 to 40 beats a minute. And remember, back from the atria, they're beating, the atria is going to beat along it naturally, intrinsically, about 70, 75 beats a minute. So 20 to 40 is super slow, too slow, way too slow to send enough blood to perfuse the tissues of your body. So when we have problems, when we have damage to this part of the heart, then we need to insert a device to restore that appropriate rhythm, and we can call that a pacemaker. All right, so this is what it looks like to have a pacemaker installed. The pulse generator that's circled there in red, that's going to be the generator of the electrical activity, and we're going to feed wires. We're going to insert that pulse generator underneath the skin, and we're going to feed the wires in through the probably the left subclavian vein into the superior vena cava, and then from there into the left atrium, and then into the right atrium, right atrium, and then into the right ventricle. And that pulse generator will send signals, electrical signals, to the heart and to regulate its electrical conductivity. Brilliant. When we get fast, rapid, irregular contractions that are not coordinated, we call this fibrillation, and this can be a problem. Now, atrial fibrillation, if this happens in the atria, is not as big of a deal. However, it still is a problem because we don't want blood pooling, right? We want the rhythm of the heart to be coordinated and normal. So atrial fibrillation, not as serious, but still something that has to be monitored and monitored and treated if there's a problem. Now, when we have ventricular fibrillation, that is not consistent with life. That's when the ventricles, your heart itself, will kind of squirm like a bag of worms, which is true. It's kind of frightening. Actually, it's very frightening. This is the pumping action of the heart is completely disrupted, right? And unless we can restore that proper electrical conductivity, then your heart and your brain tissue, because we're not perfusing anything, and then your kidneys either, we're not perfusing anything properly, and patients will die. So ventricular fibrillation, then we need defibrillators, right? And thankfully, we have more awareness and we have more access to the defibrillators. They are everywhere. Next time you're at an airport, next time you're at the mall, even here at the college, we have defibrillators on the wall in case someone goes into cardiac arrest. We can help them quickly before EMS even can arrive. All right, so when we measure the electrical activity in the heart, we're going to use some special tools, right? So when you think about measuring the electrical activity of the heart, I hope you think about EKG, right? All right, so an EKG can mean a couple of different things. So first off, an EKG can be the electrocardiograph. That's the machine. That's the machine that is built and designed to map out the electrical activity of your heart, of your patient's heart. And typically you're going to use a 12 lead that gets attached to different places on the body, though we can also use a 3 lead. Works just as well in a pinch, right? And sometimes we only use a 3 lead, like your portable defibrillators, or sometimes EMS will only use a 3 lead. All right, and then an EKG can also be called the electrocardiogram. That's that paper tracing, that's the recording of the electrical activity of the heart, and that recording shows us a composite, a mean, right, of all of the action of the electrical activity in your heart, an average. All right, so this is what a normal EKG tracing looks like, right? And to the left, you've got a diagram that kind of shows how the electrical activity flows through the heart, and then to the right, you will see how that corresponds with the EKG tracing. So now let's put it all together. The normal cardiac cycle is how blood is going to flow through the heart with each heartbeat, right? So systole is a period of muscle contraction, and then diastole is when the heart muscle relaxes and fills. And it's a dance. It's a beautiful, beautiful dance. And just like I said at several slides ago, this is a dance of electrical changes in cardiac tissue cause pressure changes in the chambers and the great vessels, which cause mechanical changes in the valves. All right, this slide I think I love this slide because it pulls everything that we've just talked about all together. All right, so starting from the far left, our atria are in diastole. The heart is entirely relaxed diastole. And as you see the P wave, the atria begin and depolarize. And during that depolarization, after that depolarization is complete, then the atria contract, and we call that atrial systole. That contraction allows blood, all right, this says it forces blood into the ventricles. Yes, it does force blood into the ventricles. It also just opens the door and allows blood to fall into the ventricles. Remember that the structure of the atrial muscle is pretty thin. It's not super strong. So the contraction here is happening, yes, but it's not a forceful one. All right, then as we get to the QRS complex, atrial systole is complete, and the atria will repolarize electrically. We don't see that, right? The QRS is the huge electrical depolarization of the ventricles, and that kind of overwhelms the electrical repolarization of the atria. So don't worry about that. We don't see the atria repolarize, but it happens. It's good. So after the QRS complex and the ventricles are depolarizing, then we get the first phase. We get ventricular contraction, and as that contraction begins, it's going to push, the contraction of the ventricles are going to push the atrioventricular valves closed, right? The pressure, the contraction of those papillary muscles are going to pull the valve closed, and then the contraction of the ventricle muscles will push again back against that atrioventricular valve, and they hopefully stay closed. Now that closing of the AV valves, that creates the first heart sound when you're listening to someone's heart with your stethoscope. All right, then throughout ventricular systole, our semilunar valves are going to open as the pressure builds. Our semilunar valves open, and blood gets ejected either into the pulmonary trunk or into the aorta. And then we see our T wave as the ventricles begin to repolarize and relax. So in early ventricular diastole, when the ventricles are just beginning to relax, then the semilunar valves will close, all right, as blood begins to flow, venous blood begins to flow into the atria, and the closing of the semilunar valves is what makes your second heart sound, all right? Then full ventricular diastole is when all the chambers are relaxed and blood begins again to fill the ventricles in a very passive way. All right, so our heart sounds are all about the valves, right? It's the closing of those valves that makes your heart sound. And when you get out into your clinicals with time and practice, you'll learn how to recognize the sound of individual valves. So my point with this now is to know where should you listen to find each of the valves, right? And how do you know if those valves are working properly? Because when they're not working properly, they are either incompetent or stenotic, and they're going to make a funny sound, and we call those funny sounds murmurs. Okay, so what does it mean to be an incompetent valve, right? So an incompetent valve won't close all the way, right? It doesn't close completely. And so when the ventricles contract, because that's where the higher pressure is, the ventricles are more forceful than the atria. So when the ventricles contract and blood gets pushed against an incompetent or a valve that didn't close all the way, then we're going to get some backflow of blood, which we do not want, right? We want blood moving in the same direction. But that backflow of blood causes a blowing or a whooshing sound, and we call that a murmur. Now, on the flip side, a stenotic valve, what does it mean to be a stenotic valve? Right? Stenosis means a tightening or a narrowing. So a stenotic valve is a valve that won't open easily all the way. And so during systole, during the forceful contraction, you're going to hear a clicking or a high-pitched noise as blood gets forced through this door that's not all the way open. All right, so when you're thinking about locating each of the valves of the heart so that you can listen for these funny sounds that we call murmurs, you're going to start on the left side of the heart. And I'm sure if you've ever been to a clinician of any kind, you've had them listen to your heart in a couple different places. All right, so the aortic valve, we can hear the sounds of the aortic valve best at the second intercostal space, right next to the sternal margin, okay, just to the right of the sternum. Then the tricuspid valve, kind of in the same place but lower. So we're going to go in the sternal, right along the side of the sternum, to about the fifth intercostal space, and that's where you should hear your tricuspid valve. On the left side of the heart, the pulmonary valve is heard best in the second intercostal space, right in line with the middle of the clavicle. So if you look at your patient and you find their clavicle, which is usually pretty easy to locate, and then you go down to about the second intercostal space, that should be where your pulmonary valve is. Now, the mitral valve is going to be in that same mid-clavicular line, but it's going to be down here at that fifth intercostal space, just to the left of the sternum, whereas that tricuspid valve was to the right of the sternum. All right, that's it for today, scholars. Thank you so much for watching, and I'll see you in class. Bye.